Hello, everyone, and welcome to this edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today is Dr. Bhaskar Purushottam, an interventional cardiologist with the Monument Health Heart and Vascular Institute. Welcome to the podcast today, Doctor. So happy to have you with us.
Thank you. Thank you for the invitation. It's happy to be here.
Now, we could, this in just my little bit of research I've been doing over the past couple of days, this is such a vast topic. We've got the veins and the capillaries and the arteries, and my goodness, can they cause problems? It seems occasionally. But we want to talk about a couple of different topics for this podcast specifically. I believe we'll break this up into two because there is so much to cover. One would be complex venous disease, and the other would be complex coronary disease.
Correct.
And I think when people hear the word venous disease, I don't think they understand what it means. So if we put this into the very simplest terms for people to kind of get a grasp of this right now would be varicose veins would be a great way to start with venous disease. Is that what you see is kind of one of the most common versions of this?
You're absolutely right. And you know, circulation consists of arteries which carry blood from the heart to the feet, and venous system carries blood from the feet to the heart. And any abnormal dilatation of these where the valves lose its competency, that results in varicose veins. It's just like driving on a road without any traffic rules.
Okay. Are those some of the, is that probably one of the most commonest type of a complex venous disease that you see?
I wouldn't really term it as complex, but yes, that is the most common presentation of lower extremity venous disease. It is so common that by the age of 50, they expect that at least every second individual will probably have some form of venous disease. And varicosities is the most common presentation. Yeah.
Is it because of lifestyle when it comes to things like varicose veins, or is it more genetic?
You know, it's a combination of factors. Mm-hmm. And the reason is, yes, you see that it tends to run in certain families, but also it's a little more common in women. Also, when you've had multiple children, that kind of puts a lot of pressure on your venous system. And also some other reasons which we don't know, which results in some changes in the enzymes of the vein wall, which starts to dilate and makes the valves incompetent. And also if you have a lifestyle and a job where you're standing and sitting along, basically, gravity starts to pull all the blood down and make things worse.
Sure.
So to answer your question, it's essentially a combination of factors.
Okay.
Yeah.
Well, now that we kind of have a baseline for what a venous disease would be, let's talk a little bit about the complex venous disease. So what are some examples of that, doctor?
So complex venous disease would be if somebody developed a blood clot into the deep system, and that start to involve the iliac veins and the IVC. These are the large veins. Think of the highway up in your belly. Then they start to become complex because they really swell up your legs. You can't do a whole lot. You start to develop ulcers. You can't ambulate a whole lot. And you're at higher risk of developing more clots. And that's when it starts to become complex. Other examples are if somebody had an IVC filter. So a filter is like an umbrella to prevent blood clots from going to the lungs. And when they get placed in the IVC, that is in the main highway or the venous system in the belly, over the years, it can get clogged up, one. In some conditions, it can start to poke through this vein wall and start to get in close proximity to the other organs, and that can be really, really dangerous. And these, are something which we are seeing more often these days because these were filters placed several years ago, unfortunately forgotten, lost to follow up, and I see a good number of them.
Now, it's interesting you mentioned the IVC, and maybe I can add a little something personal to this podcast. I have a stent in my IVC. There was a time, apparently, genetically, it didn't form all the way, and it was small, and it was caught by a doctor who said, you probably should look at getting something like this fixed. Because, that, like you mentioned, that's a very important vein in your body, correct?
Correct.
And I also remember when it was checked, I also had to do a test for clotting.
Correct.
Can you talk a little bit about that and why those two kind of go hand in hand, like you were mentioning with the clotting?
Yeah, so when somebody develops a clot in one of the major veins, then you obviously have to think of some serious predisposing factor. Mm-hmm. And what you were describing, that a part of the vein was small in size, or what we call as atresia, Either you were born with it or you had an accident somewhere and that got damaged. And you may ask the question, so how was I doing okay all this while? What happens is you start to develop bypass tracts. And the next big thing which you pointed out is, they check for certain factors and tests to find out if you're higher risk for clotting. And that is possible. And therefore, you can run a whole bunch of tests. And some tests have to be done without the actual blood thinners. And then you can find out if a person has any factors or any genetic conditions which puts them at a higher risk of clotting.
Now, it seems I'm fascinated that there can be testing for clotting, because it seems like that's just something that because can you really just briefly explain what a clot would be? What would happen when that moves into your lung or heart?
So, clotting is a normal defense mechanism of the human body. It's important.
Oh.
So if you cut yourself and if you didn't clot, you would bleed out, right? So it's important. So, but if this is aggressive, or if this is in parts of the body where it's not required because of some faulty mechanism, then that can form a clot, most commonly in the leg. And if not checked, that can progress, and with certain predisposing factors, can start to go up into the freeway, the main highway, and then eventually dislodge and go to your lungs. And in some conditions can cause instantaneous death.
What happens? What happens in your lung when the clot is there? What is it blocking?
So good. What the serious part of it, which causes death, it actually shuts off the blood flow to the lung. So normally blood from the IVC or from the other parts of the vein, they go into the right side of the heart. From the right side of the heart, they go into the lungs, and then from the lungs, they go to the left side after they get the oxygen, and then start to supply to the rest of the body. So when this clot in a decent size can go inside the right side of the heart and can block the entry into the lungs. So you get a mechanical circulatory collapse because there's no blood flowing to the left side, and therefore you don't develop a blood pressure. And number two, you're not getting enough blood to the lungs to get oxygenated. So you develop from severe hypoxemia or low oxygen. So basically twofold.
So can you have clots that happen throughout your body and you don't know? You can live with them in essence?
Actually, it's important. And that's why I said the worst form is
right.
Essentially a circulatory and a respiratory collapse. But those who develop smaller form of clots, the lung has its own mechanism or inherent system of breaking these into finer particles. And the truth be told, I think after a certain age, everybody does develop some fine clots in the legs, which do get kind of, for lack of right word, devolved, in the lungs. But when things start to overwhelm the lungs, that's when it starts to become more serious and concerning.
So what are some of the risk factors then that increase the likelihood of developing conditions like this in your complex venous disease? Are there things that we can control?
Yes, absolutely. I think some of the biggest things is, for example, you take a long-distance air travel or a long-distance car ride. You're sitting down, you're not doing anything for a good 6 hours or 7 hours. If your BMI is high or if you're overweight, you're not hydrated well, your blood becomes thick, viscous, and stagnant. And remember, the venous system, the blood flowing is not as vigorous or as fast as it's in the arteries. Okay. So when this happens, this is a perfect, storm to develop a blood clot. And in some people, you can have mechanical obstruction, so which also adds to stasis, and therefore you can develop a clot. So I would say in long-distance travels, take frequent breaks, keep yourself hydrated, and getting those legs moving, regular exercises is important. The other common scenario we see is when somebody's had a knee or a hip surgery. I'm just giving you as an example because you can have multiple surgeries. And usually in these conditions, if the patient's not very ambulatory, then that's, again, a perfect storm where you lay still, you've had a recent surgery which makes the blood a little bit hypercoagulable, and you're laying down stasis, and then obviously this forms the perfect nidus for forming a clot. So
when you were talking about travel, I know a lot of people, myself included, I don't know if this is embarrassing, will buy compression socks. Are those things that work? Can that help? It's still probably best to get up and wander around, I'm assuming.
I think it definitely helps.
Sure.
Because it prevents the pooling of blood.
Okay.
But the compression stockings is not strong enough to compress your complete deep system. Because it has to squeeze through your, your tissue, your skin, your muscle to squeeze the blood out from the deep system. So I think end of the day, staying active, regular exercise, hydration is very, very important.
So when should you seek medical attention for symptoms, or what are some pretty common symptoms for a venous disease, a complex venous disease like this? The first time you start to feel what? Should you maybe think,
So the complexity doesn't have any specific telltale symptoms. Very often, the simple venous disease and the complex, they often present with very similar symptoms. But depending on how quickly they progress, depending on how resistant they are to treatment, and depending on to what extent it's affecting your lifestyle, kind of differentiates between the complexity and the simple venous disease. So the standard symptoms are lower extremity swelling. Typically, as the day progresses, it gets worse. You wake up in the morning, it feels better because your legs have been elevated and all the blood is liquid, so it flows away. You start to see skin changes. You start to see hyperpigmentation, darkening of the skin, sometimes lightening of the skin too. And this is because when the blood pools down, blood contains hemoglobin, which then contains iron in it. And when the iron leaks out into the skin, that irritates the skin. And that's when you start to develop recurrent infections, dermatitis-like appearance. And then eventually, in worst-case scenario, you bump or you scrape your leg. You start to develop an ulcer. An ulcer is basically a breakage in the skin. And that wound will not heal because all the blood is stagnated there. It's not draining away the bad stuff to let the healthy blood to come and clean it up.
So you mentioned, when you're sleeping at night and your legs are kind of elevated.
Yep.
Is that should more people do that when they sleep? Should they attempt to elevate your legs just so you feel better in the morning? Is that a way to maybe combat this a little bit?
I think people who have superficial venous disease, or varicose veins, I think sleeping with your lower extremities elevated is good because it decompresses the vein. So remember, the more pressure, the more stretching of the vein, the more the damage, and more aggressively the symptoms present. So I think it's a good habit to keep them elevated at night. And when you wake up and in the right kind of patients, it's good to use the compression stockings and then get along with the day.
It almost seems like we weren't meant to walk upright, doctor. It just seems that everything always rushing down and it takes so much to get it back.
Especially with the venous disease,
right.
Yes. And then because when I advise my patients, especially if they're managing a hotel or if they're working in the garage, and if I tell them don't stand for too long, don't sit for too long, they say, you're basically asking me to quit work and keep me on my legs. I think it's really tricky. And what I tell my patients is, you have to see what suits your lifestyle and kind of find that balance in between. I don't expect you to keep your legs up, 20 minutes, take a break. No, every now and then take frequent breaks. And each person is different.
Right.
So you have to find that time before the window goes away, like, oh, okay, it's now time for me to take a quick break. Then I get back onto it.
Excellent. All right. Well, that's, we kind of touched there then on complex venous disease. And I think people kind of have now kind of an introductory knowledge to this. Let's move on to the next one, doctor, which is the complex coronary disease. Now, what's interesting right off the bat to me with this is we're using the word complex for both of these. So are these must be, by using that word, are we meaning the more serious of these?
Yeah.
In essence?
Yeah, I would say the best way to put this across is complexity is synonymous with increased risk of complications when performing any procedure to achieve success, and the chance of success is lower when compared to the bread and butter form of the disease.
That makes sense.
So that would be a simple way.
So a complex coronary disease, a lot of people might instantly think, oh, that's just heart disease then, right? But they aren't the same thing, right?
No, this is different. Coronary artery disease is essentially the buildup of plaque, atherosclerotic plaque, which is cholesterol, and other inflammatory products inside the coronary artery. So the coronary artery sits outside the heart, and they supply the nutrition, the oxygen for the heart to pump and beat. So it is a common problem. In fact, coronary artery disease is the main reason why we have so much mortality around the world. It's the number one reason for that.
Sure.
Whether it was pre-COVID, during COVID, or after COVID. What makes it complex is when patients have not just a 80-90% blockage, but they have 100% blockage. In that case, the artery is just living off bypasses. To try and open them to help with the patient's symptoms and survival, your risk of complications of the procedure is high, and the success rate is not really 100%. It can vary anywhere from 50 to 80%. The other form of complex coronary artery disease is when you have, the heart's got three important arteries, the right coronary, the left anterior descending, and the left circumflex. When all of them are blocked, then basically the patient's living off very little blood flow. And usually these patients, we refer them to surgery. But not all patients, are good surgical candidates, meaning they may be at high risk for surgery.
Yeah.
Then they are referred to me, and that's when we perform these complex procedures. So these are some of the basic examples of complex coronary.
Well, what are the common risk factors then for developing complex coronary disease?
And it's essentially the same as what you develop for coronary artery disease. I would say smoking, diabetes, high cholesterol, high blood pressure, sedentary, and all these contribute. But when things are not taken care of at an earlier stage, when you start to neglect these symptoms, or if you're not able to follow up with your physician on a regular basis, then the disease can progress pretty easily unchecked.
Right.
And then that leads to complexity.
Well, that would lead in to the next obvious question then. How do you know when it comes to symptoms like this? How do you know to differentiate, or if you feel them, should you automatically just get on the phone with your doctor and say, let's check this out? I
think that's your perfect answer. Yeah. If you feel something doesn't smell right, something doesn't look right, then definitely pay attention to it. And often I've seen the analogy like when I have patients in the 60s and 70s, they say, I'm just getting old, and maybe that's why I'm not able to walk, or even sometimes I've seen some 50-year-olds say, I've had a rough day. Yeah, if it occurs on a regular basis, and that doesn't make sense, you should be able to stay pretty active, climb easily a couple of flights of stairs as long as you don't have any other orthopedic impediments. And if you're not able to do so, I think it's important to question why. And yes, there are a lot of issues which can make a person not be active, but we know the most common is cardiovascular disease, and we know that is the number one killer. So therefore, it just seems pretty obvious for me that we need to rule the serious one out, And I think you're absolutely right. I think you just have to pick up the phone, call your doctor, and say, hey, I don't know, this doesn't feel right.
Right.
And then I can start asking questions, hey, what triggers this, what triggers that? And then there are plenty of non-invasive, meaning, non-interventional procedures which can try and identify this disease at an earlier stage.
Well, and I think, a lot of people, of course, are on statins for things like high cholesterol, and you have high blood pressure medication as well. Do you ever see a time, doctor, with all of your time in dealing with this system, with the heart, do you ever think there will be a time with new technologies that are constantly rolling out that we might fix a lot of this stuff? I mean, the heart seems to be, outside of the brain, the most complicated, but simple, in some instances, part of your body, right? Do you think we'll ever reach a point where we might be able to just to fix a lot of this, either with medications that keep getting better and better, it seems like, with specific surgeries, with artificial. Artificial hearts have been around for decades and decades and decades, never seem to quite get it right, obviously. But do you think that that's nearing?
Definitely. I think if you look in the entire field of medicine, and if you look at some of the most high-impact journals or most read or most respected, the two fields, one is cardiovascular medicine and the other one's oncology, where you see a lot of research being done. And also we've seen that when statins came, it reduced the number of heart attacks tremendously.
Right.
And now there are a lot more improved treatments to even control cholesterol. We've gone at least 2 folds higher than the regular statin therapy. So there's a lot more options available for patients who cannot tolerate statins. And then you have the artificial heart, that's been tricky, and one of the reasons is also the cost.
Right, yes,
and that plays a big role. But I think the other, missing the elephant in the room is prevention.
Yeah.
I think we need to pay a lot more attention. I think we need to start educating our kids at an earlier age, from eating healthy, because if you can catch this earlier on and treat it early, then you don't have to come to a stage where you're dealing with all these aggressive procedures.
Right.
Because I hate to say it, but yes, a lot of the procedures we do are life-saving, but we're not able to find that procedure where we can actually reverse the disease.
Right.
And medicines don't reverse it, but more so they kind of halt the progression of the disease.
Yeah.
And probably I think best ways to reverse it or prevent it from getting worse is a healthy lifestyle. And unfortunately, this plaque, it starts at an earlier age, at the age of 20s and 25s, and it starts to modulate, change, and eventually, shows its evil face. And sometimes 40s, sometimes,
Right.
50s. But definitely after 60, it starts to pick up.
Excellent.
And one other point, sorry, I don't mean
Yes,
to
no,
is
please.
So artificial intelligence is something which is big and slowly picking up. And in the field of medicine, and they're trying to use this to find out so many different things which can be identified. For example, looking at some person's eyes, assessing skins and genetic data. Are we able to predict with certain factors, what truly is your risk of heart disease? Yes, we have a lot of clinical prediction models, but with AI, are we able to even beat that?
So you must be excited for AI then. Is it something? I mean, I know it's still in its infancy.
It is,
really.
and I think there's a lot of controversies.
Right. Right.
Should it be regulated? But for me as a physician, when I see patients and every physician has experienced this, that, we predict something and it doesn't go right. And we see this patient in the hospital with a heart attack and I said, oh, what did I do? We took care of everything. And that's where it tells you that, human body is God's creation or evolution's miracle, and we don't know a lot of it.
Right.
It's like when you have a phone, you designed it, you know what it is. But the human body is different. So there's a lot more to learn about it. And I think with AI tool, I'm sure it'll really, really help. So I am truly excited about it.
Excellent. And I can tell your eyes kind of light up when you talk about it a little bit too. People can see that for sure. Well, Dr. Purushottam, thank you very much. Interventional cardiologist with Monument Health Heart and Vascular Institute right here in Rapid City. Great conversation. Love talking with you, doctor.
Thank you.
And I know we'll have you back again, all right?
Sounds good. Thank you.